Good afternoon and welcome to the next edition of the Rheumatology Nurse Practice Google Hangout series. My name is Kevin Lyons. I'm the Executive Director of the Rheumatology Nurses Society, and we'd like to welcome you to today's broadcast. We just wrapped up a fantastic conference in Orlando, Florida. We have a lot of exciting things coming up. This would be a sneak peek. We actually are planning a West Coast symposium sometime in February, so we're going to be in San Diego. So just to throw that out there, you'll find out more information on Facebook and through email. But today, we're going to be talking about challenging cases in rheumatology. And we have our faculty with us. We have Vicki Sales, who's with the Cleveland Clinic, and she is the treasurer of the Rheumatology Nurses Society. And we also have Eileen Leiden. And so Vicki and Eileen, welcome to RNP. The Google Hangout series. We're going to get started. And so first off, we have a brand new edition of the Rheumatology Nurse Practice coming out. If you don't receive the printed copies of the Rheumatology Nurse Practice publications, be sure to go to rnsnurse.org, click on Rheumatology Nurse Practice in the menu under Education and sign up, and we'll be more than happy to send you for free these peer-reviewed, evidence-based publications. The next one should be mailing in the next week, and it is talking about what the future holds in the treatment of RA. It's a very exciting edition. We have a lot of things being covered in there, including what correlations have been found between the use of biologic disease-modifying drugs and specific adherence events. It's a great edition. Definitely check it out. And also for 2017, all of the editions, this is our 4th edition, are available for CE. So you can now the RNS is an ANCC accredited provider of education, as well as through some of our partnerships, we offer CEs for those courses. So again, go to the rnsnurse.org website and sign up and we'll get those out to you. But let's jump into our case. This is a very quick Google Hangout. And so Eileen and Vicki, we welcome you. And Vicki, tell us about our case.
Okay. Hello, everybody. We have a 35-year-old Caucasian female. Can you advance the slide, please? Okay, she has a positive sedimentation rate and positive IgG. She has a prior medical history of ovarian cancer. She was diagnosed with that in 1996. She's in remission at this point. In her lifetime, she's had 3 miscarriages. She has kappa IgG, a vitamin D deficiency, a family history of breast cancer and heart disease. She's a runner. She runs about 4 to 5 miles per day, even with her illness. The current medication she's on are calcium with vitamin D, 1,000 units, and a 1-a-day vitamin. In April 2009, our patient developed pain in her index finger. Within the next few days, it spread to all her fingers, her wrists, and her balls, or the balls of her feet. She had daily morning stiffness for approximately 1 hour. Lab results at that time showed a positive ANA, positive anti-SSA, and anti-SSB antibodies. She was diagnosed at that point with Sjogren's syndrome. She started on hydroxychloroquine in November of 2009 to help with her symptoms. She also at that point presented with dry eyes, a dry mouth, and fatigue. She had a positive rheumatoid factor, elevated sedimentation rate, and a positive lip biopsy. She was seen by ophthalmology at that time, who confirmed a positive Schirmer test. They also did tests to rule out other connective tissue diseases, such as mixed connective tissue, lupus, RA, scleroderma, and autoimmune muscle, liver, and thyroid disease. The patient became pregnant in the spring of 2010. She delivered a healthy baby in January 2011. About 7 to 8 months after her pregnancy, she developed increased joint pain and swelling with increased morning stiffness. A workup in October of 2011 revealed erosive rheumatoid arthritis based on a positive rheumatoid factor, multiple tender and swollen joints, and x-rays revealing erosions and an elevated ESR and CRP. They added, at this point, weekly methotrexate 10 milligrams to the hydroxychloroquine. In January of 2012, she stopped the Plaquenil due to a skin rash. In May of 2012, she had a severe flare, so her methotrexate dosage was increased to 15 milligrams. Okay, so Eileen, what medication changes might have been appropriate to make during this patient's pregnancy?
Thanks, Vicki. Actually, continuing Plaquenil in this patient's pregnancy would not be the wrong thing to do. It is a fairly safe drug to give throughout pregnancy. The studies have shown to date no real increased risk of congenital abnormalities, except that we always kind of think about retinal toxicity for our patients who do take Plaquenil and therefore maybe passing it on to the fetus. So in this situation, what I would do is that if the patient didn't have any increased disease activity, I would probably just monitor them throughout their pregnancy without the Plaquenil, and then seeing if they do have a flare, would treat them accordingly. Oftentimes, people who have autoimmune diseases actually go into remission during pregnancy, which is kind of a beautiful thing. So we do often have that luxury to sort of wait and watch.
Okay. And what other medications are safe or unsafe to offer rheumatoid arthritis patients while pregnant or considering pregnancy?
So, all of our medications pretty much do have some risk of immunosuppression and side effects. So I'll just start with that. But typically, with our patients, if they flare, we do try to give a little bit of prednisone here and there. We usually try to stay low dose for starters. You do have to keep in mind, though, early on in the pregnancy, it could increase the risk of cleft palate. And certainly when you think of people who are at risk for gestational diabetes, these are just things you have to think about throughout. So we try to stay at lower doses of prednisone throughout pregnancy. Another medication is like non-steroidals you can give. It's safe to give during the second trimester, but not to the third trimester, because it can cause premature closure of the ductus arteriosus. So I typically don't give NSAIDs. I would refer the patient to the OB/GYN for that. Other medications that are known to be safe thus far with the studies we have are sulfasalazine, and again, as Plaquenil, as I discussed. And as far as our tumor necrosis factor, our anti-TNF drugs, they are also mostly safe. People do give them throughout the entire pregnancy. Pretty much all of them, except for the third trimester, you want to hold it for, you don't want to cause decreased immunosuppression of the fetus. Now, the one drug in particular that you can more safely give is Cimzia throughout the pregnancy. And that is because it has very low levels and it does not really cross the placenta, or it does so in very low levels. So that tends to be the safest drug we can give, the tumor necrosis factor drugs. Now, when we look at our other drugs like rituximab and Actemra, those drugs we just don't have enough information to date to say for sure if they would cause problems or not. So the recommendation is not to give those. And then finally, the drugs that we absolutely cannot give are methotrexate and Arava. Those drugs absolutely can cause congenital malformation, so we absolutely have to stay away from them.
Thank you. Well, it's good that women go into remission a lot of times with pregnancy, it sounds like.
Mm-hmm.
Do you think the patient's pregnancy could have something to do with their increased postpartum RA symptoms?
Yeah, absolutely. So about 90% of patients do flare in the postpartum period. So that is something that we see all the time. I would say almost the majority of the time, whereas, during the pregnancy, I think 50 to 70% of patients can go into remission. About 90% of them will flare within 3 months after the pregnancy.
Wow. And could her cutback in exercise or increase in general stress during pregnancy have contributed to her flare post-pregnancy?
It's possible, but I would say likely not, given what we know that the vast majority of patients will flare regardless. But, as we do know, stress can increase the incidence of flare. And if this patient is a runner who's used to dealing with her stress that way, I mean, it's possible that it contributed. But in this case, I would say no. And also, what I was interesting is that the patient actually transitioned to rheumatoid arthritis after she had the delivery. And that is actually really interesting because there is studies to support that, like about 3 months after delivering, that you can transition from one autoimmune disease to other. And in our case, it was Sjogren's that was rheumatoid arthritis.
Very interesting.
Mm-hmm.
Okay, in October 2012, despite the maximum methotrexate dosage, the patient's disease remains in a flare. Now she has morning stiffness that lasts about 2 hours or a little longer, worsening pain in her hands and feet, swelling in multiple proximal interphalangeal joints. They put her on prednisone, 7.5 milligrams, and in December 2012, they added rituximab. She had rituximab every 6 months for about 4.5 years, and the disease remained reasonably well controlled. So they determined she was in remission in April 2016. In December 2016, they began her on a maintenance dosing, which is 1,000 milligrams of rituximab every 6 months, and she has remained relatively pain-free since then. Okay, Eileen, how do you determine when to start a patient on a maintenance dosing regimen of rituximab?
So yeah, this is interesting that we're able to do this. We're able to give just 1 dose of Rituxan instead of 1 and then another 2 weeks later. So, as the study had actually showed about this, after they give the first dose of day 1 and day 15, and then like 6 months later or so, they were able to just give the 1 dose. And that was based on seeing symptoms decrease about 20%. So that would be about 20% less tender and swollen joints, and certainly with their stiffness decrease. So if they showed some improvement whatsoever after the first couple of doses, then by the time it's due for their next dose, I would feel comfortable giving them the 1 dose.
Great. In your experience, how successful is a rituximab regimen in keeping a patient in remission?
I've had very good success, especially if they have had that initial response. I happen to like Rituxan in many of my diseases, and I find that it has worked very well. Now, with that said, as how our disease can fluctuate and how people can lose sort of tolerance to medication over time, and we have to change from one to the other. I mean, that does happen. So that goes without saying that can happen regardless. And we're just used to that with our diseases. But in general, again, as long as they're starting to respond, I've had very good success.
Great. And with her personal history of the ovarian cancer and her medication history, do you feel there's a concern or an increased risk of lymphoma with this patient?
Yeah, I think, well, she has an increased risk of lymphoma just based on the fact that she has the history of Sjogren's syndrome. Patients with Sjogren's syndrome do have an increased risk of lymphoma. So that alone, if a patient that patient in particular started having night sweats, fevers, rapid weight loss, some lymphadenopathy, increased LDH. Like these are things that you would absolutely have to be aware of and get on top of, because there is that potential association. And the other thing that about her medication, actually, that's a positive, is that she's getting Rituxan. Now, Rituxan is one of our drugs that we actually don't have to worry about any even small increase of developing lymphoma. It actually is used to treat lymphoma. So that's a good thing in her case. As part of her history, though, she has a monoclonal gammopathy of unspecified significance. Now, this is like a precursor to potentially lymphoma and also multiple myeloma. It's one of these blood tests that we check. So, again, it's a precursor, but it's not there yet. But in this patient, I would refer her to a hematologist just to ensure that if she needed to get a bone marrow biopsy, or let's just say a skeletal survey, if you're worried about multiple myeloma, that she'd be well taken care of. Again, because there is association with lymphoma, I would be a little bit more on top of her for that reason.
Thank you.
So, yeah, and one other thought I had about this case that I also thought was really interesting, because she was pregnant and she has this history of Sjogren's disease and she has this positive SSA antibody. They're at more increased risk of having their baby having neonatal lupus. So this is a patient that would have to be referred to a high-risk OBGYN and have frequent cardiology monitoring, getting echocardiograms, because the baby could develop congenital heart block. They can get a lupus rash and some other symptoms as well. So I just thought that would be important to bring up with this case. Very interesting case overall, though.
It was.
Yeah.
Wow. Well, thank you both. That was a very interesting case. Are there any final comments or thoughts that you would have, Vicki or Eileen, as we wrap up the call today?
I don't think so. I found it very interesting, the lymphoma aspect of this case. I actually read some studies in which about between 5 and 44% of patients do develop lymphoma than the normal population. So that was a really interesting fact when I was reading about this case.
Yeah, fascinating. Eileen, any closing thoughts?
Just that it's not so common when we see our patients coming in with these joint pains and stuff that primary Sjogren's is the primary diagnosis. We usually think of our other diseases. So I thought that was really interesting that, that's how the patient presented at first. And then right after pregnancy and her postpartum, then she transitioned to RA. So that was just more unique, in my years of taking care of patients. The way it's set up was a little more unique. So it just makes you want to be a little bit more aware of these presentations.
Very fascinating. Well, thank you both. Thank you, Vicki and Eileen, for joining us today. This is our new series of the Rheumatology Nurse Practice Google Hangouts, where we do a little shorter, piece of it. We feel it's important to get the information out to you as quick as possible. And then don't forget, this is available for replay. So if you have colleagues or friends that you would like to share this case study with, simply go to our website, rnsnurse.org, and you can click on Rheumatology Nurse Practice under the Education tab and get to all of the previous recordings of the Google Hangouts that we've produced over the years. So we also want to announce our next Google Hangout is going to be on Wednesday, October 4th at noon. So it's going to be another 20-minute Google Hangout, and we'll have 2 more faculty joining us. And then, of course, for up-to-date information, follow us on Facebook. Go to Facebook and Rheumatology Nurses. And then you can also look for us on our website at rnsnurse.org/RNP. Don't forget to sign up for your free copies of the printed copies of the Rheumatology Nurse Practice publications, as well as digital copies are available on the website too. We also have many other CE offerings and other benefits of looking on the website, and definitely we invite you to become or consider becoming a member of the Rheumatology Nurses Society as well. So we look forward to the next Google Hangout, again, Wednesday, October 4th. And Vicki and Eileen, thank you so much for your time. And we thank you all for joining us or watching the replay. Have a great day.
Thank
Thank
you.
you.